I'm Becky Sutton, one of the ST6 trainees currently at Queen's. I've done this project with Natalie Cooper this year. We sent out a survey and from that we're hoping to improve the quality and efficiency of supervised learning events for the trainees and the trainers. So a little bit of background. As I'm sure we all know, there's a new curriculum for anaesthetists in training that commenced in August 2021. And from that, the old terminology of work-based placed assessments was changed for supervised learning events. Importantly, there's now more emphasis on supervision levels, and a certain supervision level is required by the end of each stage of training. So we sent out a questionnaire to all trainees in EMSA this year, February, to assess any recurring challenges the trainees are finding, in the hope that we might be able to improve things for everybody. So here I've got the Royal College Entrustment Scale. So a supervision level is required for completion of each SLE, and this shouldn't reflect what the supervision level has been provided at the time of the activity, but what the trainee would require should they repeat that activity right there, right then, so right here, right now. So just to outline the different supervision levels. So supervision level 1, the trainer would be expected to be needed directly supervising the trainee in theatre. 2A, they could be in the coffee room. 2B, within hospital, so they could be pre-opping for the afternoon list, for example. Supervision level 3, so they could be at home and able to provide queries, available for queries over the phone. And 4, completely none the wiser that the trainee's doing anything. And to emphasise, it doesn't need to be the case that this is what's happening, but this is what would be needed. So this slide is just a graphical representation of the increasing independence or supervision score that you progress through training. So the ultimate aim is that by CCT, a trainee should be able to function as independently as a consultant. So at each stage of training, the specialty-specific domains of the curriculum will describe the level of supervision that should be demonstrated by the anaesthetist in training at the end of that stage. And by CCT, the trainee should be able to achieve the supervision level that's been depicted by stage 3. So survey results. So we've got 89 responses with a nice mix from stage 1, 2, 3, and 1 trainee out of programme. The first question was when the trainees mostly send their SLEs. So they send them at the time or retrospectively, and everybody states that most of the time they send them retrospectively. Okay, so are there any recurring obstacles to sending us our assessments in real time or for quick approval? So 59 out of the 89 trainees stated that a lack of device or internet in theatre was an issue, and 76 of the 89 stated that a lack of time during the list was an issue. So other I directed them to the comments section at the end of the survey, for which I think pretty much everyone had something to say, so they've just not all clicked other, I think. Does the trainee initiate discussion about supervision level with their trainer? So blue is usually, and orange is occasionally, so it's a bit of a mix, but majority do some of the time. I think it's probably a summary of that. How often does the trainee feel there to be discrepancy between the level of supervision that's been discussed versus what is documented? Blue being very often and orange being often. So you can see that just over 50% of trainees feel that there's a discrepancy between what's discussed and then what's documented on their assessment. 2 of the questions were to try and work out how we could improve things. So do the trainee feel that a worksheet outlining the supervision levels might help in discussing with their supervisor? And the majority felt that either yes or maybe. That may be helpful. And in answer to having more devices to enable real-time sign-off or at the time assessments would be helpful. So blue is yes, so about 50%, and maybe was another significant proportion of trainees. So that might be helpful. So here I've just highlighted some of the recurring themes that were brought up in the comment section. So I'll read through them. I know it's a lot of text, but I think they're relatively important statements. So there seems to be a poor understanding that supervision level on the SLE is important, and it needs to be the level that we think could be achieved rather than, sorry, that they think we could do something rather than the level that was supervised on the day. Agreement of a specific supervision level. A time lag between sending and being completed, and therefore some decay in the assessment or quality of the assessment. The LLP constantly logging me off. I think that is an issue when you're trying to do stuff at work, unfortunately, because the Wi-Fi signal is not necessarily as great as you may experience at home. Trainer unfamiliarity to the new curriculum. Not understanding the weight of supervision level for the new curriculum, getting solo night shift work evidenced, as may not have contacted the consultant at all. Some supervisors do appear to have the time to do a quick approval, which I think is the same for everybody, isn't it? It's difficult in the midst of a list, and they want to do it at a later stage. Maybe having some time at work to be provided to get some balance of work-life balance and potentially impacting well-being, I think it's being alluded to there. It's burdensome writing these assessments up in the spare time. It would be great if we were encouraged to do them in theatre complex, although it does feel a bit rude to whip out your laptop and start typing away if it's not suggested by the trainer. Most interesting cases happen out of hours, and I would add to that arguably valuable from an assessment point of view. And some consultants have been reluctant to sign off these events. Due to the LLP no longer contacting consultants to inform them, you end up having to send an email separately. I'll comment, I don't think that is now the case, whether it was historically with the new curriculum, I'm not sure, but that I believe not to be the case any longer. So the college's response to these concerns is recommending that we do the quick agreement option, it's now called. It used to be called the real-time sign-off, I think, in the old curriculum, as opposed to a retrospective sign-off. And that would naturally encourage discussion between the trainee and the trainer regarding supervision level. As far as addressing the lack of devices, well, great news is we've got e-prescribing coming soon to NUH, and with that, lots more devices will be available. And my understanding is that is a device to each theatre. So lack of time. Well, if we can find more time on the list, then this arguably saves time both for the trainee and the trainer. And this would encourage discussion, as we've alluded to, and arguably a more accurate assessment. And as it stands, the trainees are probably repeating these assessments, because if you don't achieve the supervision level that's needed for the stage and that had been agreed, then you're going to have to send another assessment. And obviously that requires another trainer to sign off that assessment. So that's more precious time spent on SLEs for trainers and trainees. As far as the worksheet, so we could make this entrustment scale more so readily available on the new devices as a reference or discussion point for supervision levels. On-call assessments, does the on-call anaesthetist seem to be the most appropriate person to approach? Having discussed this with several consultants, I think that may be the way forward, but it'd be interesting to see what the consensus is here today. So with that, I suppose what we're suggesting is that if it may or may not have been discussed at all with the consultant on call, so an email to the on-call anaesthetist requesting the assessment and outlining the case if it's not already been discussed. And it's not an obligation, but it's an opportunity that the trainee might otherwise have not considered. And this is particularly relevant in stage 3, where we are encouraged to evidence on-call work, both for multiple modules, so general anaesthesia, ITU, transfer, resus, trauma, and sedation. So in conclusion, the issues highlighted from this survey regarding supervision levels must be and will be disseminated to all the trainers within EMSA. The discrepancies between supervision level discussed and then documented causes an unnecessary increase in workload for both the trainee and the trainer. The quick agreement option recommended by the college, but this doesn't seem to happen for reasons that I think we can all understands there's just not necessarily a lot of time during a list, something else to worry about. This could be addressed by encouraging SLEs to be undertaken in theatre with the use of the new devices. And ultimately, supervision levels are important. Thank you.